Good morning, everybody. I think it's time to get started. And I assume there are more people on Zoom than there are physically present in this room. So today it is my distinct pleasure to welcome Dr. Jensen Hyde to Grandrounds. Dr. Hyde got her undergraduate degree from Vanderbilt in cellular and molecular biology, and then went on to get her degree in medicine from UT-HSC in Memphis, and did her residency in these hallways in this hospital. And during the 3 years here, she was an absolute rock star, was awarded the Resident of the Year, was awarded the Resident Research Award as well. And I'm told that soon there will be a star in the Walk of Fame in her honor on East 4th Street or East 3rd Street because of the number of TV appearances she's had over the past 2 years talking about the COVID pandemic. Anyway, during this whole period with the COVID pandemic and everything else, Dr. Hyde has obtained her master's in public health from Columbia University, no less, on a merit scholarship. And now she's an assistant professor of medicine and an APD in the internal medicine department. I can tell you that I have spent many years trying to recruit Dr. Hyde into our division, but it's been the gain of the internal medicine department and the residency program that she's chosen to stay in her true love, which is internal medicine and hospitalist medicine. So today, Dr. Hyde will be talking to us about hospitalist medicine. Welcome, Jensen.
Well, that was truly mortifying. All right. Weird cabinet down here. Okay. Good morning. So the original title of this presentation was not COVID, and I was told that wasn't descriptive enough. So we're going to talk about hospitalists. So I don't know that anyone has financial disclosures in this particular realm, but I thought it was very interesting to go back and see how an entirely new specialty develops in less than a decade. Y'all are all training in a period of time where this is fairly ubiquitous, but that was not always the case. And as anybody who's ever worked with me knows, I love what I do. I think I have the best job in the world. I think people outside of hospital medicine don't necessarily understand sort of some of the draws to it. But I also didn't come into medicine wanting to do hospitalist medicine. I was going to be an intensivist. 100% was what I was going to do when I came in. And I still love critical care. But I think that I have sort of the best of all worlds because I can shoot the breeze with the guy that's watching General Hospital because he's waiting for placement. And then I can have some people that are in the ICU as well. So this is just a roadmap of the general path we're going to take on today's journey. So we're going to talk a lot about the origins of hospital medicine. In order for something to arise as an entirely new field in less than a decade, it's going to take a considerable amount of pressure from outside sources. So we're going to talk a lot about what those contextual pressures were, particularly in the late 80s, early 90s that led to the rise of hospital medicine. We're going to talk about some of the essentially holes that needed to be filled and the ways that hospital medicine filled them. And then we're going to look at the evidence about whether or not that mission was at all accomplished. Because at the end of the day, we need to look at our system and say, is it better than where we came from? And then we'll talk about some future directions. So this is the current accepted definition of what it is to be a hospitalist. So whenever you invent a word, you have to define it. And it went through a few different iterations, but this is per Society of Hospital Medicine. Physicians whose primary professional focus is general medical care of hospitalized patients, but other activities include patient care, teaching, research, and leadership. The word hospitalist was kicked around a lot in the early 90s, but wasn't really formalized until this paper, which was essentially an op-ed in the New England Journal by a guy named Robert Watcher. You'll see his name come up a few times. He's a professor of medicine at University of California, San Francisco, and did a lot of the early and present work in this field. But this paper was 1996. So before 1996, there wasn't a published statement of what it is to be a hospitalist. What does that mean? Although it was happening in different capacities across the country. So before we talk about the change in the system, because many of you are younger than me, what did it look like before? So there's a considerable amount of variability, but I think it's sort of interesting to understand what the system looked like prior to sort of the separation of inpatient and outpatient medicine. So in the 70s, there's a huge rise in subspecialties within medicine. So it became very hot to be a cardiologist, to be an intensivist, to be a gastroenterologist, and all those fields were really developing during that period of time. And that was a very popular thing to do. It was less popular to be what was called a generalist or a GP, but that is what we would refer to as a primary care physician today. And what that meant in the 80s, and again, there's some variability geographically and individually and like any sort of how you practice medicine, but the overall crux is essentially that you saw patients in the clinic primarily, and then you saw some patients in the hospital. And the classic model of that was that if your patients were admitted to the hospital, you would see them. Now that model was built when there was a little office here and a little hospital here, and all of your patients always came to you. And then if they got sick, they always went to that hospital. And it worked reasonably well when that was the case. But increasingly with urban and suburban sprawl and general rise in the size of cities and increased mobility, that no longer really became the case. Practices got much bigger, hospitals got much bigger. There were multiple hospitals for patients to choose from. And the idea of always seeing your patients every time they went to the hospital became a little bit strategically difficult. And so a lot of private practice groups formed groups where they would take a hospital week. So if you had a 10 physician practice, you would do 1 in 10 weeks covering the hospitals, and you would cover all of your group's patients who happen to be in the hospital. And that gave a little bit more flexibility. They would probably still see some patients in the hospital during that week, but it gave them a little bit more flexibility. So in that case, you may be seeing your doctor, but you were sort of playing the odds. If you went to the right hospital, you had, a 1 in 10, 1 in 6 chance of seeing your doctor, but you were maybe going to see somebody in the group. There's still a lot of pediatrics groups that function this way. On the academic side, it was a little bit different. So there was a group of academic generalists, still spent roughly 11 months out of the year in the clinic, but they would do week-long stretches covering the ward teams, the house staff teams. So they'd see some patients in the office, they'd come in early in the morning, they'd round with the house staff, they'd come back in the afternoon, they'd round with the house staff. But 80 to 90% of the time, it was just the house staff in-house, and they were holding down the fort, as it were. And then the academic generalists were covering somewhere between 4 to 6 weeks a year in the hospital. So kind of with that context, we'll talk about some of the things that happened in the 80s that made this system both no longer feasible and also no longer desirable. So I'm going to separate some of the key driving pressures into 3 buckets. So the money, the technology, the acuity of illness, and then the GME medical education component. So as always, you can follow the money to figure out what some of the heavy-handed driving pressures are. But as most of you are aware, we used to operate in this country for many, many years on what is known as a fee-for-service model. So you do X, you get paid Y. You do 2 times X, you get paid 2 times Y. And that was the system for a very long time. It's much like the system if you go in to buy a TV. This is what it costs, this is what you get paid. However, healthcare costs have risen exponentially since the 60s and 70s in this country, and that became essentially seen as a misaligned motivation. So it was motivating physicians to do more when it maybe necessarily wasn't in the best interest of the patient. And also, we had to curb costs. So in the early 80s, the managed care model started to take foot. And essentially what this did is it said it's not going to be quite so simple. You're not going to just get paid for each and everything you do. There's going to be caveats to that. There's going to be limitations on what practices patients can go to. There's going to be limitations on what procedures can be done. There's going to be limitations. There's going to be a cap on how much you get paid to do certain things. So you better figure out how to do them efficiently, and you better figure out if they really need to be done. And so managed care is a big umbrella term. This could be an entire lecture that I'm not going to get super into, but just understand that there was a pretty big change in the way that physicians were paid. So this was sort of the classic fee-for-service era. Patients could go wherever they wanted. They had unlimited choice in physicians, and physicians had unlimited choice in how and what they wanted to do. The pendulum swung pretty hard in the HMO era. This probably predated all of you, but this was a pretty limited managed care model where you were pretty limited in who you could see and what you could do. And long story short, everyone hated HMOs. Physicians hated them, patients hated them. They had a huge PR issue. It was considered, essentially care rationing. And so the pendulum swung back to sort of a middle ground of competitive managed care, where there was still limitations and still motivations for efficiency, but a little bit more choice. So this is sort of the financial context in which we're having this discussion. I'm not going to go into all of this, but I think this is a great graphic. This is from a white paper it's called DRGs to Nirvana. It's a really dramatic name, but basically about the various forms of payment reform. So in 65, Medicare was signed into law, which essentially instantaneously insured a whole lot of people. We instituted DRGs, or diagnosis related groups, as sort of an initial way to reform billing. Those still exist, HMOs in the 90s. And then here's some of the things that have happened since then. Still a work in progress. What did this do to generalists? So the rise of managed care initially was actually kind of a good thing for our brand, so to speak. It made generalists a little bit more relevant again, because there was very much a gatekeeper role, particularly in the HMO era, where you needed to go through your PCP. You couldn't just go see Dr. Chloride if you wanted to. You needed to go through somebody who said, yeah, that's appropriate. So it sort of brought the generalists back. But at the same time, there was tremendous pressure to be efficient. So that meant that when you were seeing patients in the office, they wanted value. They wanted to be able to see you when they wanted to see you. They didn't want to have long wait times. They didn't want you to be out of the office for hours at a time. And then you needed to be doing things that you were getting reimbursed for in order to essentially make up the difference in what you were paid under the old model and what you were getting paid under the new model. And that meant that spending 3 hours in the car on a given day to drive around to multiple different hospitals to see 1 or 2 patients didn't make a lot of sense. And so there was a tremendous amount of pressure on the outpatient doctor to improve efficiency. And then on the inpatient side, there was a parallel pressure from the hospital systems to improve inpatient efficiency. So we're going to move into the second bucket that has to do with healthcare technology, but also with increasing acuity of illness. Medical technology is great, but it's also very expensive. So during the 70s, 80s, if you think about what was happening with computers and how that dovetailed into what was happening with our ability to do medical imaging, to do diagnostic testing, to have access to medical records, it was a tremendous boon to medicine in a lot of ways. But it also rapidly expanded the number of tools we had in our toolbox to do our job. And what we know is that about 1/3 of healthcare dollars are spent in the hospital. So with this rise of technology, with technology being expensive, with not everybody knowing how to use the tools, and with a tremendous amount of pressure to be more efficient, there was a lot of attention paid by hospitals to how patients were cared for in the hospital. And there was a lot of motivation to really tighten that up, to make sure that patients were not staying in the hospital longer than they needed to, that they were getting the tests that they needed, but not all the extra ones, and that all these new fancy, shiny things that were coming online were being used by people who knew how to use them. So there's a lot of attention paid in parallel to efficiency on the inpatient side, as well as efficiency on the outpatient side. And this is when hospitals really started hiring their own doctors. This was initially for sort of that unattached patient, but it became more and more common, particularly in systems like Kaiser and in California that were already highly networked systems. I like this just because I think it's interesting, but it shows you where we were at this point. So keeping in mind, this is where these things were invented and give a lag time for when they came online. But we basically went from Band-Aids and penicillin to kidney and heart transplants in the span of about 10 to 15 years. So in the 60s and 70s, transplant became much more common. CT scans were invented in 1975, but really came online kind of in the early to mid 80s. MRI followed that. And then in 85, dialysis, and this was a huge, huge deal. And you can see in these little ovals here, the way that life expectancy ticked up with each of these things. So you sort of the net effect of all of these things is that we now had immunotherapies and chemo regimens and CT scans and MRIs and cardiac catheterization and valve replacements and dialysis, and people were living longer. And when they came to the hospital, they were a lot sicker. So, patients that would have been admitted to an inpatient ward in the 1950s probably wouldn't make it past our triage desk now. It's just a very different acuity of illness. And so the demand on the patients that were in the hospital, the demand that they had for monitoring and for care went up pretty exponentially during this time period. And then the last sort of component, last driving pressure bucket that I'm talking about is the component of how house staff, how residents played into all of this. So follow me on this kind of blue brick road, I suppose. Most of you probably are familiar with the Libby Zion case. If you're not, read it over. It's one of those things you should just know about. But long story short, it was this 1984 young patient that died, likely an avoidable death. Her father was a journalist and really dove into sort of the circumstances of her death and uncovered, so to speak, what all of us knew and were living, and that was the working conditions of house staff. And you can imagine, if you talk to your friends now, they're appalled by how much you work. Imagine if you were a resident in 1988 and you worked 40-hour call shifts every third day, and you were telling the general public about that. The general public was outraged. They said, I can't believe this. We limit airline pilots, we limit air traffic controllers, you're doing surgery on my mom. I can't believe you'd work this much. So it really sparked sort of a national outcry. They also were a little bit appalled by how little supervision the house staff had. But this sparked a pretty significant debate within the medical community. And I think in a lot of ways, this is still going on, because where is the line? Right? Residency is a limited amount of time. If we don't give you enough experience and we don't give you enough exposure, are you long-term more of a risk being out unsupervised and inadequately trained versus how much is it reasonable to have you work while you're in residency? And again, this is still very much going on, but this is the origins of that. So in 1990, ACGME passed the 80-hour work week. It was categorically ignored for about 9 to 10 years. It was like one of those things on paper. ACG sent you a lot of paper, and everybody said, yeah. And then in 1999, To Err Is Human came out, which Dr. Youngblood mentioned during her talk as well. But essentially another put on your to-read list if you've never read it. But it was basically an expose put out by the Institutes of Medicine about medical error. And again, this is a very complex topic. There is no one factor that leads to medical error, but it did really reinvigorate this idea of duty hours and of really better regulating resident training. And so after To Err Is Human was published, the Congressional Oversight Committee actually weighed in on medical training, and that gave ACGME sort of the teeth it needed to enforce the duty hours that already existed. And they sort of famously put Hopkins on probation, basically very classic, like, we're going to make an example out of you, this could happen to you too. And since then, duty hours have actually been very strictly enforced. Whether or not that has actually improved outcomes, the data is pretty mixed, but that's a topic for another day. But the net effect for the purposes of this discussion is that there was a demand for better oversight of trainees. So a attending medicine physician that was actually available and not doing a concurrent office practice. And then they also lost a lot of cheap labor when we started limiting the number of hours that residents worked. So while residents were historically kind of the catchment for unattached patients or patients at big hospitals that were taking care of them, there were less bodies in the hospital for less hours to take care of those patients. So there was a work vacuum as a result of duty hours. All right, so what happened? So in that 96 Watcher paper, he described sort of what he was seeing around the country, that hospitals were hiring their own physicians, or that physicians were forming groups where they only saw patients in the hospital. They used sort of a block schedule. They had plans for cross cover and plans for night coverage. And he made some sort of, if you read through it, it's quick, it's a 2-pager kind of thing, but he made some sort of prophetic predictions about how this would take off, and sort of predicted this would become a dominant model. spoiler alert, he was very right. He lowballed on the numbers. He said he thought there would be 30,000 hospitalists in the next 10 years. So hospital medicine is the single fastest growing field in all of medicine every single year since 1997. To this day, continues to be the single fastest growing field. It has grown exponentially. 2000 is the latest sort of accurate numbers. There's about 60,000 physicians that identify as hospitalists. The next closest is cardiology, about 38 to 40,000 cardiologists. Vast majority of all hospitals nationally use the system. Every single academic medical center has gone almost exclusively to a system of using inpatient doctors for inpatient work and outpatient doctors to teach residents outpatient. Okay. Coffee time. So hopefully I've kind of outlined the context and some of the reasons. So there was a need to improve the balance for physicians. There was a need to allow doctors to be efficient both in the hospital and out of the hospital. And there was a need for kind of bolstering resident education. So the model took off, and it really took off. And as you all know, it's how things work at this point. But it's always important to ask, if we think we're changing a system for the better, did we actually change it for the better, or did we just change it? So I'm going to go through some of the evidence on efficiency and quality as a result of hospitalists. So this paper was published in JAMA by Watcher and Goldman, so the two kind of OGs of hospital medicine, and it's a review article. Keeping in mind that this was only about 5 years after they wrote the first paper. So at this point, the hospitalists, this is in the early 2000s, hospitals looked different a lot of places. It was a lot less standardized. So doing a review on outcomes was a bit tricky because you don't want to compare apples to oranges. So they did a pretty thorough review on papers that were published between 96 and 2001, looking at hospitalist models that they considered within sort of a narrow range of how they operated and then appropriate controls. And this was the first big publication showing significant benefits. So they showed a reduction in resource use, about 13.4% reduction in hospital costs for patients cared for by hospitalists versus patients cared for by non-hospitalists. And then an average reduction in length of stay by 16.6%, which, as you can imagine, is very attractive, particularly to hospitals and to patients, and then to providers as well. And then a big concern, and one of the big issues brought up by those who were anti the hospitalist movement, was that we were going to create this system that was very burn and churn. Like, yes, you can definitely get them out of the hospital faster if you're there all the time, but if they are going to have worse outcomes, are you really helping anything? And so this paper showed no difference in inpatient mortality or readmission rates. So since then, there have been a lot of sort of better quality papers looking at this because it's been more standardized and you have the ability to sort of compare apples to apples, so to speak. So this was actually a prospective quasi-randomized study where they compared patients on teaching within teaching services. So the Watcher stuff was by and large at a mix of teaching and non-teaching. This was all at a teaching hospital. They compared about 3,000 patients cared for by teaching hospitalists. So academic physicians, much like the ones in this room that were caring for patients on the wards with teaching teams, compared to academic non-hospitalists. So we're still operating under this. I do a couple weeks in the hospital a year, but I also see clinic patients. And there are about 6,000 of those. And this was from 2002 to 2004. So not actually that long ago. And they looked at length of stay, readmission, and then 30-day mortality. And they showed a significant reduction in mean length of stay of close to a day. And then interestingly, that the reduction in the length of stay was significantly greater for high acuity patients that they stratified by DRG. And then for those requiring complex discharge planning. So you can imagine why that would be, that if you were there and able to kind of work those difficult problems and spend the time during the day, that might reduce their length of stay versus spreading that out over a few days. There were also no significant differences between the groups in readmission rates, in hospital mortality, or 30-day mortality. And then in 2019, Solomon et al. Put out a really large meta-analysis, basically looking at all of the legit papers that had been done on hospital medicine, comparing hospitalists to non-hospitalists on a number of outcome measures. So the jury is no longer really out on whether or not hospitalists reduce length of stay. That's very clear. So this is just a forest plot of all of the studies. You can see that all of them favor hospitalists, most of them significantly. There have been specific studies looking at reduction in length of stay by diagnosis. So for heart failure, pneumonia, COPD, and stroke, hospitalist admission further significantly reduces length of stay. And then all these studies showed equivalent, or in some cases, reduced in hospital and 30-day mortality. So the other thing that I brought up when this initially took hold by some of the naysayers, patients are going to hate this. They're going to hate seeing all these random people. Like, I can't believe you would do this to your patients. So first, I will concede that if you have a patient that has an established PCP and you offered them the chance to see a stranger or that person, they're going to pick that person. But remember what we talked about in what the real system was at that point. So you might see somebody in your primary care group. The likelihood that you were going to see your doctor for the duration of your hospitalization under that old system was still relatively low. And that was if you went to the right hospital and if you went at the right time. So this data is not talking about this. This data is talking about, what do patients think about being cared for by hospitalists after they're cared for by hospitalists? So this is that same Solomon et al. Paper. They looked at, you can see a number of studies spanning a number of years, and they looked at hospitalists versus non-hospitalists and asked patients essentially a variety of satisfaction questions. So friendliness, courtesy, how well they kept you informed, how good you felt like their skills were, the time they spent with you. And every single one favored hospitalists, many of them significantly. And then this one's actually pretty recent, last year. And I think it's well designed. It's out of Korea, but it's a case control. So they put patients by ward to a hospitalist versus a non-hospitalist ward. And they did pretty extensive regression against a lot of potential confounders. So they looked at age, sex, medical division, the region they were from, the level of acuity of illness, whether or not they were surgical, whether or not they were ICU, and then multiple comorbidities. So they regressed against all of those things, and then did the odds ratio of answering these questions favorably. So there were favorable answers and there were unfavorable answers. And so I highlighted some of the interesting ones. You can see they all fall in favor of hospitalists, but attending spent adequate amount of time in consultation, procedure, and care services. The odds of answering that question favorably for hospitalists versus non-hospitalists was 2.4 times. Answer to my question related to care, 2.39 times higher in hospitalists. Communicated fully, 1.79, not in a rush, 1.94, skill, 1.86, fund of knowledge, 1.65. And then interestingly, and this is, I think, a Korea specific thing, but willingness to pay extra, the odds of being willing to pay extra were 44 times that in the hospitalist group than they were in the non-hospitalist group. I don't know if they would offer that as an option, but so they don't hate being cared for by hospitalists. So hopefully I have at least proven the value somewhat of the system, but that's not to say it's not without pitfalls. And I think that those of us who trained in a system where this was all we knew sometimes only see the pitfalls, and that's okay. But I think it's important to recognize the advantages and then also to see what we can do to improve the pitfalls. So one of the perceived and is actually a pitfall of the hospital system is that you're creating intentional discontinuity. You are separating inpatient from outpatient. And when the goal is to care for patients comprehensively, why would you do that? Why does that help? And so this is true. You are separating the two. And it really brings to light the importance of things like discharge summaries and things like talking to people as PCPs. And we're going to talk about transitions of care in a later slide. But this is definitely a thing that existed before, but probably was made worse by implementation of the system. One concern that I think has effectively been debunked, though, is there was some concern that it would cause detriment to the physician-patient relationship, that if you weren't there for your patient in their hour of need, that it would do negative things to the relationship, which I sort of understand conceptually. But what has been found is that what's also really important to patients is being able to see you when they want to see you in the office. And so if you can't get in with your PCP, and you start seeing other people, or you start going to urgent care clinics, that also does a pretty significant amount of damage to the doctor-patient relationship, versus if your PCP is available to see you and can be in the office and can staff full clinic days and can see you, efficiently, that also matters to patients. And so that one I think is not really borne out. Redundancy of care is a system-wide national issue. I don't know that necessarily is made worse by hospital medicine, but certainly if there are some outpatient testing that you don't have access to, the likelihood of repeating that inpatient when you may not have if you had access to their clinic records is certainly there. Advantages, we've talked about some of these already, but I do want to touch on some of the ones that we have not. So practice makes perfect sounds like something you would tell like a 5-year-old t-ball player, but this has been shown again and again and again in the medical literature. The more times you do something, the better you are at it. So this data originally was really, really strong in procedural and surgical fields, but has been extended to medical fields. So the more times you treat a complex pneumonia, the better you are at recognizing when that patient's about to crump, or when they might need a chest tube, or when maybe you need an antibiotic change-up. The more times you see something, the better you are at handling it. And interestingly, and I put this in italics because I think this almost sounds funny to say out loud for people who didn't know a different system, but hospitalist medicine actually significantly reduced the use of consults. Because in the prior system, if you weren't going to be there, the default mode was that you were going to consult anyone and everyone from the outset that could potentially help you with that patient, because you weren't going to be there a lot of the time. So hopefully somebody would be there if they needed to. So if you had a patient that had some stable chronic conditions, you were probably still going to consult cardiology, pulmonology, and GI as a default. So with the presence of an on-site physician, the need for that was significantly reduced. And that actually was a concern by a lot of subspecialists when hospitalists came online, is that they were going to lose business because they weren't going to get consulted as much. So we talked about on-site availability. I think expertise in systems-based care is also really important. So length of stay probably is reduced some by this experience level, by being there, by some level of expertise, but a lot of it is reduced by the fact that you just know the system really dang well. So if you know that you need to talk to Kate Perry, if you need a form printed out, and if you know that you got to talk to PT before they go to lunch at 2, if you want that form in to get to Siskin by the end of the business day, and if you know that if you don't get insurance approval by Friday morning, they're not going to SNF till Monday, those are things you don't know unless you just work in that environment. And those are things that over time make a big difference, even if you're just shaving, hours off of discharge, or a day or 2 here. Over time, that makes a big difference, and it helps when you know how to navigate the system. Experience also has to do a lot with comfort level with high acuity of illness. So I am much more comfortable with somebody on 2 pressors than I am with somebody who has a rash. Please don't show me a rash. I don't like them. But the same goes, the converse goes for folks who really love outpatient medicine. They may not be as comfortable with high acuity of illness. So it's allowing people to practice in a practice environment that they're most comfortable with and most experienced with. Internal medicine is incredibly broad. So in a lot of ways, to divide by acuity of illness can be helpful in allowing you to hone a certain set of skills. Quality of life considerations are huge. I think a lot of people, the perception is that outpatient docs didn't like having the hospital taken away from them. I have not found a single one who wishes that they had to come in on nights and weekends to staff hospital patients. I think quality of life on the outpatient side is very important, and then quality of life on the inpatient side is very important as well. So I think we benefit one another that way. And we'll talk about involvement in other realms in the next couple of slides. Okay, so I'm going to talk a little bit about future directions and sort of how the field developed and legitimized itself. Any questions so far? I just need a chance to take a sip of my coffee. Okay. So, hospitalist tracks and fellowships. So I've tried to sort of highlight the ways that medical education was a really big both driver for hospitalist medicine, but they also were pretty early adopters of understanding that this was going to be a big part of what a lot of internal medicine graduates would do. So internal medicine programs were very quick to adopt using academic hospitalists because they knew they needed to meet this need to better supervise their residents. Resident satisfaction was a lot higher with having and academic hospitalists do their ward time because they were more experienced in that realm, and they were also more available to the residents. So resident satisfaction actually went up with the use of these as well. So academic programs went to this model pretty readily and then did some pretty early things to improve and to essentially update their training programs to reflect this change in the field. So the vast majority of internal medicine training programs have a focus, particularly on the wards, on what hospital medicine can and should look like. And then some dedicated specific hospitalist training has become nearly ubiquitous. So whether it's an elective like we have here or a formalized track, a lot of programs have a way to provide additional training in hospital medicine during the residency years. Fellowships. There are hospitalist fellowships. There are about 40 or 50 total in the country, and they fall in a couple of different realms, but there's been pretty significant resistance both within the field and on the hospital side about requiring hospitalist fellowships. So a lot of us who go into hospital medicine don't want to train anymore. We would like to work. We're, 40 or whatever, and would like to have our first real job. And then hospitals, the demand still outweighs the supply of hospitalists. And so the idea of them waiting an additional year. And then because of a lot of things the training programs have done, there's a question of whether it's really necessary to do another year. But the programs do exist, and they're actually a really good option. A lot of these I didn't know about, of course, have a glutton for punishment. And I'm like, maybe I would do that. But a lot of physicians looking for sort of next level involvement in certain fields. So there are about 40, 41 administrative and then research quality based fellowships that are 1 or 2 years. They're frequently associated with the second degree. So either an MBA or an MPH or an MHA. So for those folks that are interested in doing research, quality, patient safety stuff, or admin stuff, being involved in hospital administration. So those are potentially a really good option. And then there are a couple dozen that are geared towards our friends in family and pediatrics. So to date, and updated numbers on this are hard to find, but about 80 to 85% of hospitalists are internal medicine trained in the United States. There are the rest, the 15 to 20% of the rest are made up by family medicine, pediatrics, and the occasional emergency medicine folks. So there are fellowships geared towards folks from family practice and pediatrics who want a little bit more experience before making hospital medicine a career. So these are potentially a really good option for the right person. As we sort of developed as a field, we have now a set of core competencies. There is also a board exam, which I don't know if anybody who's taken, but it does exist. We have our own journal that was creatively named The Hospitalist. I think that was probably a very short meeting. And then right after we reached our 20th anniversary, there was the C6 billing code. So this sounds super boring, but I am going to talk about it for a second because it's actually really, really important. So Centers for Medicare and Medicaid, CMS, has billing codes that they designate to each specialty. So GI has one, cardiology has one, urology has one, general surgery has one. And it's how they basically identify who you are and what you do. And until 2017, so a good 20 years after hospitalists were very common, all internists, generalists had the same billing code. So how CMS uses this is that they use it to track utilization of services across the country. So how often are people going to the doctor? How often are people going to the hospital? What things are you ordering? What are you doing? They use it to track data nationwide. And then they also use it to benchmark you against people in your own field. So how do you do compared to another internist in your city versus one in Washington versus one in New York? So for about 20 years, we were comparing apples to oranges, and the data was just trash. So it was basically, utilization was all over the map because the codes that you use when you are taking care of patients inpatient are totally different than the ones that you bill for when you're outpatient. They're completely different. And so they were all being thrown into one big bucket. And then furthermore, you couldn't benchmark yourself because you didn't know who you were benchmarking yourself against. Were you benchmarking yourself against somebody who did 100% outpatient? Were you benchmarking yourself against somebody who mixed time or another hospitalist? So the C6 billing code was a very big deal and makes the data after that point much more useful in determining outcomes and resource utilization. So to my mind, the biggest focus, I think, for us for care, for improvement as hospitalists is in coordination of care. And this falls into two big buckets. So handovers and transition back to the PCP. So I'll talk a little bit about handovers first. I was sort of surprised. I thought when I did a deep dive into this, I was going to find some like wonderful system that somebody else used that like we could just adopt and like move on with our lives. And there's not a lot out there on it. And I think the reason is that the volume is highly variable. And then the practice organization still has a lot of variability. So people still organize their shifts and their practices and their handovers differently at different places. What we do know and what we've known for a long time is that handover improves patient outcomes. It is a big patient safety thing, and that verbal handover is better than written. However, when you try and apply that conceptually and try and scale it up from, hey, I'm handing over 14 patients from one team to another team, once or twice a day. Anybody want to take the over under on how many handovers, if we did it here, we would do a year for the hospitalist side? So keeping in mind, we use an admitting service, we use a nocturnist service, and then we have turnover hospitalists. It would be about 900,000 a year, individual handovers. So we have 42 full-time hospitalists, 15 APPs, and then transitions from nocturnists, admitting docs, rounding docs, discharging docs, and then doc to doc. So doing IPASS 900,000 times sounds sort of like the seventh circle of hell. So it's not to say that there shouldn't be a handover system. We need to do better. This is a very significant area for improvement. I just think it's going to involve some creativity. It's also going to involve us all kind of stepping up and maybe doing a little bit extra in terms of whether it's a written handover or the way that we transition doc to doc. The thing I think we are doing better on is coordination of care between the hospital and the discharging physician. This also has a lot of work to be done. And I think a lot of this can be done with really simple changes to our essentially rounding and discharging behavior. So very easy things that we can do. And if you've ever rounded with me, I will sound like a broken record. Ask the patient who their PCP is. If I get another discharge summary that says no PCP attached, no PCP designated, you have to ask them. A lot of times they have somebody they see. And if they say they don't, then find them one. There are case managers that can help with this. There are coordinators that can help with this. But if we're sending somebody out of the hospital with the hopes that they will call a number you gave them to establish care, have y'all ever tried to be a new patient at a practice, even as a doctor? It's really hard. And we know that patients who are seen within 7 to 10 days of the hospital are less likely to come back. They're more likely to have their needs met. They're less likely to do poorly in the next 6 months. So we need to give them every tool possible. So if you get them a PCP appointment, you say, here's your appointment, here's your time. If they don't show up at that point, yeah, it might be on them. But to say, hey, here's an 800 number, good luck, is not the same thing. So ask them who their PCP is, make sure it's recorded correctly in the chart, because the PCPs do automatically get some information if they are designated as the correct PCP. And you'd be surprised how often, just because one is listed, person's like, I've never heard of that person. Or yeah, I saw them once 10 years ago. I think they're dead now. It's just like, it's usually not the correct one. So ask who they are, always send the discharge summaries to the PCPs, and try whenever possible to have them an actual PCP appointment when they leave. We're using more care coordinators, which are another useful tool. So you may have seen this in your Dodson patients where they have a transition of care note. So it's somebody who will call them after the hospital and say, hey, were you able to fill your meds? You feeling okay? Are you going to come into the office? And those have some good data as well. But I think there's some small things that we can do to improve that, and then definitely room on the system level. So leadership is another interesting thing that I think a lot of hospitals have really gotten into, and in a lot of ways are uniquely suited to. So not only does the schedule allow it, but you also have the benefit of knowing the system really well. So if you want to be involved in the system, it really helps to know how it works and to potentially come up with some creative solutions. So you're seeing a lot of hospitalists end up in C-suite positions, which I think is very important in a time where we need physicians as leaders, because we're increasingly getting to where we don't want to do that. And then we're mad when non-doctors are making decisions for doctors. So it requires doctors to step up and make decisions for doctors. The immediate past head of CMS was a hospitalist, and this is Vivek. He's the current Surgeon General of the United States, and he's a hospitalist. This is not me, but it's my picture. So the other thing that we're also seeing a lot of is this model being expanded to other specialties. So intensivists being the early on ones, they used this model actually pretty early on for covering the ICU, particularly folks that don't do the pulmonary side. The other one that we're seeing very commonly is laborists. So OB/GYN trained folks that do not have an office. They do shift work either contracted by the hospital or by OB/GYN groups. So the OB/GYN groups will do the prenatal and the postnatal care, but the laborists will do the deliveries. Surgicalists are also being hired to do acute care surgery, essentially taking the call, doing the cases as they come in, and then they'll maybe do 1 or 2 days of clinic a month as follow-ups for the cases that they did. But they don't see patients in the office. They don't do planned cases. They basically take care of what comes in. And then in some larger systems, they are having some hospital-based consulting services. So pulmonologists that just do pulm consult service, GI that just does GI consult service. So it's being expanded to other places. So a lot of this y'all already know, but I think a little 4 things is always a good way to wrap things up. It's really important perception is so important, and we take for granted now that we know what a hospitalist is, that patients will also know what it is. Patients see so many of us. We come in and we come out, and y'all are on consult services, and your jacket says internal medicine, but you're with nephrology, and then the med student comes in, and you all ask the same questions, and you ask different questions. It's really confusing to patients. It's really important that we all step up and help patients understand who they're seeing. So introduce yourself every time you go in the room and tell them who you are. And if you want to add something else about what your role is, bonus points. So, I'm Dr. Hyde. I'm one of the hospital doctors. I honestly don't say hospitalists. I say I'm one of the hospital doctors. I'll be taking care of you while you're here. If I'm seeing a surgical patient, I'm Dr. Hyde. I'm one of the hospital doctors. I'm going to help the surgeons manage your blood pressure. And that way, when the patients have a concern, they feel like they know who they can ask. Because a lot of times they'll say, oh, I don't think I actually take this medicine. They'll bring it up to ortho at 5 a.m. and they'll get shot down, and they won't feel comfortable bringing it up again. Versus if somebody says, hey, you're going to be seeing a hospitalist later. This is exactly what they're here to help manage. I'll reach out to them, but when they come by, ask them that question. So explain who you are, what you do, and then it gives patients a lot of empowerment to feel like they know who to ask and also what you're all doing there. All right, chart integrity. EHR is a bit of a double-edged sword. It has a lot of wonderful things that it offers all of us, but it also has a lot of pure garbage. So making sure that no matter what service you're on, no matter what field you go into, that you take chart integrity as a personal responsibility. So if you know that somebody doesn't take a medication the way it's listed, fix it. If you know that they never had AFib, take it off their problem list. If you know that they had an allergy listed that's a very common side effect, take it off their allergy list. Do things to make sure that the chart itself is as high integrity as it can possibly be. And then particularly for those of you who are going to be consultants, if you are going to sign off, click over to the discharge tab and make sure that your follow-up information and any instructions are already in there, because you can't guarantee that the person that you talk to throughout their hospitalization is going to be the discharging physician. So now, and I'm about to rag on them again. I know we rag on orthopedics a lot. They're really good at that. They put their stuff in the discharge. They put their weight bearing. They put their follow-up stuff. And it's really helpful because a lot of times it's not what I would have necessarily guessed, especially when it's like, oh, they want them on aspirin for 30 days. I'm like, so, do that, make that a practice habit. You're going to do that when you see patients, particularly when you're signing off, make sure that they have the information that they need. And Epic actually gives you a really quick and easy way to do that. It's great if you talk to the person. And then this can apply to the primary team as well. So a good example that comes up more often than not, you've got a patient that needs a sleep study. Put in an ambulatory referral to sleep medicine in their discharge orders the second you think of that and pend it. Because if you go off service, the likelihood that somebody else is going to pick up on that to the point where it will translate to the actual referral becomes relatively low, because when you're handing over these patients, you're handing over their active issues. Same with follow-up for pulmonary nodules. Same with people who need to see an endocrinologist. Go ahead and put it in there and pend it. And that way, when the person goes to discharge, it'll strike with them. They'll say, oh yeah, they do need that. And they'll leave it and they'll sign it. And that way the patient can get it for follow-up. Understand an appropriate use of hospitalists. So again, I love what I do. We're here to help. I'm happy to help in any way, shape, or form. It's not our job to do your paperwork. Like any consultant, if you don't have a specific question for them, then they probably shouldn't be there. However, complex patients that are medically complex or patients that are acutely complex have 5 or 6 consultants. It's a very appropriate use for hospitalists. So a lot of what we do is coordination, right? I use the word quarterbacking because patients tend to understand that in this part of the country. You're quarterbacking, right? And that means coordination because a lot of times the consultants don't necessarily talk to each other, but they may talk to you. And there are times where you need to tell a consultant, hey, I don't think we need to do this because so-and-so is going to do this. You see this a ton with nephrology and imaging studies, contrast with surgical procedures that are planned on consecutive days when they can be done on the same day. So a lot of what you need to be doing here is helping people talk to each other and coordinating. So maybe their medical issues aren't super active, but if there's a coordination component to it, that's a really important part of what we can and should do. Considering transition of care, so I think general surgery does a good job of this. So rather than defaulting to admitting to a hospitalist, admit to the service with the acute problem. And then if it becomes no longer their acute problem, then considering a transition of care to a hospital service, I think is very appropriate when the primary issue is no longer surgical. And then something that we've talked about, and I think is we need to step up in offering and also hopefully have that followed by people using it, is the medicine consult. So using a medicine as a consult service for specific problems rather than as the default admitting service can be a really good utilization of those resources. All right. And then lastly, I think it's really important that we continue to talk to each other. I know that secure chat gets to be a lot, but I also think it's a very useful tool to be able to contact the people directly involved in the care of the patient to make sure that we are talking about what's going on and what's being done. This is a hospital, and this is not the case everywhere, where consultants write orders. That means it's very important to know what's going on with your patient. That way you're not making decisions and writing orders that are going contrary to what is already in the chart. So talk to people. If you run across somebody in the hallway and you have a mutual patient, talk to them about it. You're almost always going to get useful information from that. And then if you talk to somebody about it, be really clear about the delineation of responsibility. So, so-and-so needs a CT. Okay, am I going to order that or are you going to order it? I'm happy to do it, but I just want to clarify. Making sure that you're doing that both within the inpatient teams and then on the transition of care is really, really important. So in summary, it's not perfect and it'll continue to evolve, but it offers clear value both educationally and monetarily. It's also not going anywhere. But there's tons of room for continued improvements. In a lot of ways, hospitalists are uniquely poised to make some of those improvements within our own system. Questions? I see that up here. Mhm. Mhm. Yeah. Yeah, I think I'm going to try and distill that down. So what Dr. Mafilio is saying is basically was this initially just a failure to reschedule ourselves to where we were basically doing, essentially half the year inpatient, half the year outpatient? Would that have kind of better split the difference like a lot of subspecialists do? Or is it inevitable that we're all just going to kind of specialize ourselves into a whole? I don't know the answer to that, but I do think that is just one component of it, is the scheduling component. So I agree. I think if you get somebody in, although I think at most you would still have roughly half the inpatient days that somebody who does full-time inpatient or full-time outpatient does. So there would be some experience gap there. I think some of it was just provider preference, right? So it was attractive to not have to maintain an office, to not have to have, that constant inbox when you're off, to not have, so I think that a lot of it was provider preference. I don't know that it's inevitable, but I do think the provider preference thing does transition or does apply some, and maybe correct me if I'm wrong, but does transition some to some subspecialties, particularly those folks that are very subspecialized. So I think about George Phillips, Harish Maniam, folks that are in these subspecialties, but really their thing is a few steps removed. And I think if they had their choice, they might not choose to cover the general service as often as they are, but I don't know that for sure. So I think some of it's just preference, and then some of it has to do with volume. And then in internal medicine is a little different too, because the breadth of what you're expected to be proficient at is pretty wide. And so dividing that by acuity was actually sort of an easy way to separate it, because you're not going to divide it by diagnosis. You're not going to have the luxury of doing that. And at that point, you're just specializing. So I don't know that it's inevitable. And I think to a certain extent, a lot of it depends on practice location. So, I've talked about the Kaiser system in this too, but they're very, very networked. And so they tend to do that. They tend to put people in more specific boxes versus if you go somewhere rurally, everybody's still practicing in sort of this older way. So I think it depends a lot on your personal career preferences and then on your location of practice.
Thank you for the shout out for pulmonary sleep. I appreciate that. But there are probably folks in this room who are thinking, hey, I'm a year away from deciding. Do I follow Jensen High? Do I do something?
Well, don't follow me. You'll get lost.
There are many institutions that are subspecializing in hospitals. So, for example, at Yale, you're a hospitalist for the oncology service. That means you only admit oncology patients. That's all you do. You work for them. You're a hospitalist for the orthopods. That's what you do. How extensive is this trend, and does it defeat the purpose of being good at hospital medicine in general versus subspecializing in one brand of hospital medicine? So I'm wondering if you could address it.
Yeah, so I think that's a good question. Dr. Sethi asked this trend of actually subspecializing within hospitalists. So being an ortho hospitalist or being an onc hospitalist, it is relatively prevalent, although I think it's something that's just being tried on for size right now. We did it here. Amy Welltower did it for ortho for a while, and she's no longer doing it. It's very attractive to the other services. I think it's less attractive to us. Part of what I really like is seeing a variety of things. And so particularly on ortho, you're not really seeing a whole lot of variety. We're also not seeing a whole lot of acuity, but it is something that's being tried. There is a lot of really good data on co-management models. So trauma hospitalists, geriatric hospitalists with trauma, and then orthopedic for total joints, and for ortho trauma, co-management with hospitalists improves not just length of stay, but mortality. So there's very good outcomes data on that model. I think what probably works better, and I think what some of the larger hospitals are doing, is to have you do some time on those services, but not have it be your entire professional life. So you would maybe do a week as the ortho hospitalist, and then the next week you would do general hospitalist, or a week as the trauma hospitalist, and then next week do the other. So that might be a way to strike the balance, because but I think the benefit there is really more from having a hospitalist co-managed than having the specific dedicated hospitalist. I don't know that there's much in the way of like additional skill that you learn, although I'm sure there's some. Yeah, exactly.
Thank you.
Yeah.
lot of higher for hospital practice. The other direction, hospital medicine.
Yeah. So the question is, do I see more family practice folks? So that data lags. So I think it's probably higher now. Here it's definitely higher, but I do think we're a little bit outliers. So it depends on how quickly we reach an equilibrium about supply demand mismatch. I think I have wonderful family medicine colleagues that do a very, very good job, but our training is so focused and dedicated in so many ways on hospital medicine that I think if you are not really trying to hire somebody to fill a role and you have the choice, that you potentially be a more attractive candidate coming from internal medicine. So I don't know that it's going to swing significantly, but I think it definitely already has swung probably closer to, I would say 15% non-IM folks. And then it may continue to swing more. I don't know that it'll swing much more than that. Yes. So the question is about hospitalists doing essentially intensive care. So there's two parts to that question. And there was a whole portion of this that I didn't have time for to put in here that actually talks about that specific question, but it's a great question. So there's two sides to this coin, right? The data is very good on intensivists being involved in intensive care patients. To my knowledge, there's not a lot of data suggesting that taking hospitalists out further improves data, but it's more just the idea of having intensivists involved. There's really good data on closed ICUs for lots of other reasons. So I think that that's sort of an ideal system. But the fact of the matter is there are nationally not enough intensivists. So the flip side to that coin is you need the training in it. You need to be proficient in it, because a lot of places you go, you're either not going to have an intensivist at all, and you are going to be the intensivist, or you're going to be charged with sort of this step down level of intermediate care that does involve a lot of critical care concepts. So yes, there are better outcomes if you could have an intensivist for every patient who needed an intensivist, but the reality is that there's just not enough. And so you need to have hospitalists that are proficient and comfortable with that, particularly in outlying areas where you don't have a formalized critical care system. I don't know if you can speak more to that. Mm-hmm.
That I'm familiar with was at Western, Ohio State, and they had a 6-month rotation. And during those 6 months, we then decided, and a lot of residents took that up because they didn't know what they wanted to do thereafter, and they wanted to have extra competency hospitals if they were going to a slightly smaller hospital without skills. And so it was pretty popular, and there are more programs like that across to address that need, because you are not going to be able to provide intensivist example in the hospital. East is a perfect example where you can allow that.
Yeah. There is no cap. Yeah. Yeah. You're going to find out next month when you do the rotation. So the question's about volume. Yes. So in the very early days, there was a tremendous amount of variability in how many patients individual hospitalists would see. There was, some competing interests as far as, okay, if I'm here, I might as well be working. I want to make sure I'm hitting targets, et cetera, et cetera. Since it's become more formalized, there are guidelines from SHM about what are considered sort of appropriate or targets. And it's somewhere around 16 to 18. I am not familiar of anywhere that can contractually guarantee a cap. Part of what we do is seeing the patients that come in the hospital, and that depends very heavily on the hospital volume. And that works in both directions. There are times where it's on the low side and you kind of wish you had a few more people to see, and there are times where you're seeing 25 people. So it swings in either direction. A lot of places do use, and we do as well, a sort of backup system where you can bring in somebody who's effectively on call or available to kind of reduce the burden, either admitting or rounding. I think for some people, it might be a consideration as to what their average numbers are, but I don't know that anywhere is going to be able to guarantee you that you are going to always see X number of patients, because that's a lot of that's out of their hands. Certainly I think where the census is consistently high, that's usually the lever that's usually pushed is on hiring. And because of value added, it's pretty easy for us to justify hiring more people when the volume supports it. So when I started in 2017, our census was consistently, Eric, you remember, it was at least 2022. And then, this is when a lot of actually the FM hires happened, is we needed people to round. And so we hired a few people, and that the pendulum has swung a lot of that because of bed closures. But you can do hiring and scheduling in a way that tries to anticipate the census, but none of it's going to be guaranteed. I'll go to work. Thanks for coming. Mm-hmm. Yes, I saw it. I saw it last night, but I was not on my work. I will.